if you are someone who can kind of push through to an extent, and people mask it, and it kind of becomes at a point sometimes where it's like, well, if I don't know how long this is going to take, and I am going to try to do what I can. And I think for me, the reality was, if I could show up at school and my grades were still good, and everything on surface level feels okay, we're not completely off the rails here, then it kind of just became something that it wasn't a priority.
Welcome to Endo Untangled, where we explore the quiet complexities of endometriosis and pelvic pain, one thread at a time. I'm Dr. Alicia Macro, GP and founder of Thrive Endo Clinic. And this is my colleague, Cherie Noble, exercise physiologist and pelvic health educator.
Hi.
Together we're here to explore the complex tangle of hormones, trauma, fatigue, neurodivergence, movement, and really get down and explore some of those stories that we rarely hear. Because pain is never just one thing, and untangling it takes time, compassion and curiosity. And we're so glad you're here. Today we're joined by Sophie Sheppard, a physio and researcher who brings a refreshingly human, nuanced approach to pain, fatigue and care. So before we go further, Sophie is a physiotherapist who specialises in helping people living with ongoing pain, fatigue and invisible illnesses like chronic fatigue, fibromyalgia and long COVID. She understands what it's like to live with some of these conditions herself and brings some lived experience into every part of her work. Sophie takes a whole person approach, looking at how things like the nervous system, stress, sensory overload and neurodivergence can affect how we feel in our bodies. Her care is gentle, supportive and focused on helping people feel safer and more in control of their symptoms without pushing through or ignoring what their body is telling them. Sophie works online through her clinic, Vive Pain and Fatigue, and is currently doing a PhD looking at how people in rural areas experience pain care. Sophie is passionate about changing the way pain is understood and treated, making space for both science and lived experience and helping people feel seen and supported. Sophie Sheppard, welcome to the podcast.
Oh, thank you so much for having me. I need you doing all of my introductions to everything I do. That was great.
She's so good at it, isn't she?
Sophie, what I love hearing about in podcasts, especially in ours where we're meeting with a bunch of different experts, and often a bunch of different experts who have lived experience in this area, I would love to hear a little bit more about your story, both as a physio and as a human. And what drew you into this space, working with fatigue, pain and invisible illness. And what I would say is, until I met you, I didn't know that physios could become titled as pain physios. So that was new to me. And so I'd love to hear some of your story.
Yeah, sure. And look, it's always hard to work out exactly, how much or how to frame that journey, because there's so many different elements that come into it. But I guess for me, I ended up gravitating towards physio pretty well straight out of school. I knew that I was interested in biology and health, and I was kind of always a bit fascinated with, how the body worked. And so I knew I wanted to do something in that realm, and was really struggling to find something that really, spoke to me or interested me. And, I tossed up the idea of doing medicine, and then I just knew enough through my mum working at a medical centre in the town that I'm from as a receptionist, but from seeing through her experiences just the reality and the chaos that can come with that, I sort of went, I don't know that I could do that. And I particularly, we touched on lived experience before. Unfortunately, I have a lot of lived experience of ME-CFS or chronic fatigue syndrome, and that was predominantly throughout my high school years. So I'd spent a lot of time in the lead up to sort of getting to uni that had been really quite restricted after a viral illness, and it had really impacted me on quite a lot, and actually probably influenced some of that decision early on, because I wasn't confident knowing what I knew about what would be required going into medicine, whether or not I could maintain those demands. So it probably did factor in that way. But yeah, I went into physio and went through the standard, 4-year physio training. I got really interested in the nervous system and the brain, and thought I would potentially gravitate towards the neurological side of physiotherapy, which is one of the core areas that we learn about. But then I went on a placement and was exposed to a allied health-led pain clinic at Traralgon Hospital, and that really kind of piqued my interest and then got me started on this journey about being really fascinated about pain and the complexity of it. And I think that was really then cemented when I went out to practice. I got a job in a musculoskeletal private practice in Wagga, and pretty much immediately came out and realised that a lot of the ways in which we are taught throughout physio to kind of understand problems and to treat people really wasn't cutting it. And I had so many patients that I would see that had gone through, you know, traditional rehab. They'd sort of done all the right things and things just still weren't quite progressing the way they had. And I guess for me, I didn't cope well with not understanding that. And I was like, well, what, you know, if this isn't going well, like I need to learn more. So very quickly went down the the chronic pain sort of journey, went down the rabbit hole, did a lot of extra sort of postgraduate training in that space and lots of ongoing learning. And I say pretty quickly, I guess, niched into that area. And you touched on the titling before. That sort of was the culmination of that, I guess. I completed my master's at University of Sydney in pain management. And then for those of you that aren't familiar, the titling is effectively it's not specialization, which is its own thing, but it's sort of the level below specialization. So it's a mark of, I guess, you've done significant study and training, usually master's level study in a particular area of practice. So that was in 2022, and I've sort of been practicing in that space ever since. And I think by association, almost going down the pain pathway, where there's certainly a lot more recognition, it's not handled or treated particularly well, I would say, generally still. But I think even more so when we start looking at fatigue and invisible illnesses, that's very much an area that's underexplored. And interestingly, despite my lived experience, it wasn't my lived experience that sort of got me interested. It was kind of through the pain pathway. I was like, hang on, there's a lot of overlap here, and like, what's going on? And then once I saw those connections, it was hard to rein it in. So I kind of then ventured from there, and yeah, it's just been a bit of an exploration.
Like your patients are lucky to have you with your training and interest, and you can certainly see how passionate you are about this particular area, and what you were just saying then is probably a good segue to, like, my first question is, you know, experiencing and knowing what we know about what's going on in this space and how it's being navigated. Like, what did you see that was missing when we're trying to manage and treat like pain and fatigue in particular and invisible illness?
I guess there's a fair bit of complexity to it, right? And I think you could probably look at it at a few different levels. But I think at a clinical level, for me as someone who was trying to treat patients, what I was seeing and what I was feeling was that, you know, I'd be interested to see if you two agree with this, but, you know, the way that I was taught, and I think most professionals are taught, is through a very, I would say, sort of simplistic, almost linear way of looking at issues in the clinic. So if someone comes in with a health issue, it's like, okay, well, to figure that out, they're going to have X, Y, Z symptoms, and then that's going to give us this really clear diagnosis. And if we know what that diagnosis is, then there's really clear X, Y, Z treatments, and then that person's going to get better.
Yep.
And I'm seeing a lot of nods.
Yeah,
so.
let's follow the clinical guidelines, and then that should resolve.
Yes, which is how we go into clinical practice, and then it's quite shocking when those patients don't follow the rule book and don't necessarily get better immediately with what we are told is going to be the answer for them.
And that was kind of what I was seeing, I think, and probably a common problem I hear from people who are sort of, I guess, keen to work more in the pain space is that, like, health in general is complex. You know, there are so many factors at play, and our bodies are really complex, and we're never going to fully, you know, I guess, understand or completely predict every possible sort of interaction that happens at these different levels. And what that means is that we're then trying to really simplify these really big, complex, you know, wicked problems down into really simplistic solutions. And what we see is often that just doesn't work. But then you're kind of left sitting there going, well, like, how do we then tackle that? Like, we need different frameworks and ways of thinking of things to kind of approach it with and respect the level of complexity and, I guess, the challenges and a degree of uncertainty that there often is involved in working with these complex conditions. I think that goes for all health conditions, but particularly when we're talking about pain and fatigue and invisible illnesses, where it is a very sort of murky area in sense of, like, lots of overlap and complexity, and we don't necessarily have the best research or full understanding of those conditions yet. So
And if I can take a brief segue on where we're at. Well, not a segue, it's all tied in. Would love to get your thoughts on neurodivergence and the complexity of adding that into the mix as well in terms of what you see with, again, pain, fatigue, these conditions and the connection with the neurodivergent population.
Yeah, I mean, this is such a huge and I think still underexplored area. I don't think we've got anywhere near enough research fully fleshing this out, but certainly we're starting to realise that, particularly if we look at ADHD and autism, that there are these increased rates of pain and chronic fatigue and chronic illness and particular conditions that have really been shown to be higher risk in these groups. And particularly when we start exploring things like hypermobility disorders or Ehlers-Danlos syndromes. And so we're starting to get there and recognise that there are these connections, but I think it's challenging because, people who are ADHD or autistic are probably more likely to develop pain and fatigue conditions and maybe have some of these other related health conditions that can impact on their symptoms and their day-to-day function. But in addition to that, because of their autism or ADHD, the way in which their brain and nervous system processes and interacts with the world may not necessarily match with the way we've established health services and the way in which we might naturally want to interact as health professionals. So not only are they potentially more likely to have these problems, but there's also added barriers and quite often negative experiences of people trying to seek care. And I think that when we consider some of the unique aspects of neurodivergence, like, for example, things like sensory sensitivities or sensory processing differences, or even just executive dysfunction and the added cognitive load that often a lot of people experience, that when we then think about the implications of those on pain and fatigue symptoms, they sort of become these areas that I think are really valuable to be able to work with people on and to kind of explore options to address them. But unless we kind of acknowledge and practice in a neurodiversity affirming way, we're not really opening ourselves up to the opportunity to explore that with people. So yeah, I think it's an increasingly recognized area, but there's still a long way to go for us.
Absolutely. It's so refreshing to hear you say that. And I think that it is twofold. It's that prevalence that we're seeing and also how these people are experiencing pain as well. And that may not look exactly like a lot of people are experiencing those symptoms. And you touched on a lot of good things there that we definitely see here in this population.
So many rabbit holes for us to go down there. But before
Alicia's going to bring us back in because we can go down. You and I feel like we can really go down this pathway.
Yes.
Bring us back in, Alicia.
Okay. So one of the things, Sophie, you have been open about is that you mentioned you've had your own experience with chronic fatigue syndrome as a teenager and also have lived experience with neurodivergence as well. Can you reflect on your own experiences, both as a patient or an individual sort of coming to terms with trying to manage chronic fatigue, as well as understanding and getting your head around what it might be like as an individual with neurodivergent or neurodivergent individual, and how those experiences might inform your work now?
Yeah, it's interesting, right? Because all of these reflections are, I guess, somewhat retrospective. It's one thing for me to look back now with all of what I've learnt and sort of make sense of it. But I mean, I think at the time, in terms of my journey from a neurodivergence perspective, so I am late diagnosed ADHD, so autistic and ADHD. And so that's a very recent sort of frame through which I'm viewing a lot of my past experiences. And it's interesting to kind of reflect back and sort of see how there might have been some of these overlaps and how the two might have potentially danced off each other a bit. But I guess at the time, I was in my early teens when I first had my onset of ME-CFS, and it was, I would still say, in the scheme of ME-CFS, mild. Mild is anywhere up to 50% reduction of day-to-day activities, which doesn't sound mild to anyone who doesn't have it. But in the scheme of what we see for ME-CFS, I would count myself as on the luckier end of things. But, I was really limited in my ability to do things. I had to basically drop out of all my sport and anything outside of school. I would go to school and be absolutely exhausted by the end of the day, come home, crash, sleep until dinner, maybe get woken up to eat and then go back to sleep. And so it really had quite a profound impact. And looking back, I can see how potentially that did, I guess, relate with my experiences of being autistic and ADHD. I think a lot of the added challenges that often come with that. So for me, I'm quite a high masking person. So I was probably part of the reason why I was very late diagnosed. But in retrospect, looking back, how much of my day-to-day energy when I would have to go to school or be in social situations, there's so much added cognitive load and energy that goes into interacting with other people, because you've almost got this running meta commentary in your head of like, oh my God, like what's everyone else doing? Am I coming across weird? How do I hold my face? What do I do with my body? Like, how do I interact like a normal human being? And so even just those day-to-day experiences, not that neurotypical people might not necessarily feel some of those social anxieties from time to time, but it's a significantly increased burden when that's happening all the time. And so I think certainly that drain on cognitive and emotional energy absolutely had an impact on my fatigue symptoms. And
can I ask you as well, like, do you also, not only are you interacting with the group and like you were saying, thinking about yourself and how you're being perceived and what's going on, but do you also have that expanded view of being able to, like, there's just so much other sensory input coming in as well? So you've also got, you might be in a cafe where there's like a lot of noise and there might be bright lights going on and then there's things going past, and it's like you're taking in all of that as well as trying to figure out what's going on with all these people and you, and it's exhausting just to be in that space, let alone have, hypermobility on top of that. And not that I'm not sure whether you do as well, but just I'm thinking of our patients that we see, and then having what's going on physiologically as well. It's a lot. And I hope anyone listening to this is kind of, maybe having a wake-up call if you and sort of starting to recognise that this is maybe what's going on for you and can affect your experience of pain and fatigue.
For sure. It's huge. And the sensory processing is a massive thing. And I think that's, again, until I was looking back and after my diagnosis, I didn't realize how much of that was not a normal experience. That's not everyone's typical experience. And 100%, the thinking, or to generalize or try and simplify it down, basically the thinking is that for a lot of people, who may be autistic or ADHD, whereas, normally the brain would sort of do a pretty good job of filtering out a lot of extra sensory information around us to stuff that's maybe the most relevant or pertinent. So it kind of cuts down on the level of noise coming in, not noise just in terms of sound, but sensory noise, and all of the different sensory signals we're getting, that a lot of people who are autistic or ADHD don't have that. And so they're just getting this sort of like unremitting stream of everything coming in. And it can be really overwhelming. And yeah, totally. I definitely notice for me, even now, if I have to spend time in a louder or I guess more intense environment, whether it's louder, whether there's lots of stuff going on, whether there's more social interaction that I'm having to process, like that has direct, impacts on energy levels. And unfortunately, sort of in recent 6 months, I've had a little bit more of a relapse of my ME-CFS. And so for me now that I have that extra insight, I'm definitely aware of the impact of those things. And you have to be quite strategic, I guess, in terms of some of the things that I might do. And that's a lot of what I work with patients on too, is, if we know that sensory processing is part of this experience for you and something that can have a really big toll, like how can we modify this and how can we maybe approach it in a way that works for you and how it shows up for you so that we can kind of help, I guess, soften the impact of those day-to-day activities.
Sophie, before we move on and talk about pain more generally, I'm just interested, I gather your experience of chronic fatigue or ME-CFS happened in a country environment where I imagine you would have been visiting country GP, possibly physio in the country with your symptoms, fatigue, whether there was pain, those sorts of things. I'm just wondering if you could reflect on that experience as a patient with an invisible illness, I guess now through a lens of being a pain-titled physio.
Yeah. Look, I think my experience at the time probably reflected the experience of what is still similar to what a lot of people experience.
Wow, really?
We have some very, very, we had fantastic GPs in our area. Like, we were very lucky, and I had, I guess, more of a personal connection to them because my mum worked at the practice. So like, I was probably coming from quite a privileged position in that sense. And I think the reality is that even now, ME-CFS is just still not particularly well understood, and there's not broad understanding of I guess the breadth of things we can do to manage it. So while I was probably lucky in that after being sick with my viral illness, which at the time with the viral illness itself was sort of significant enough that I did have to be admitted to hospital. So I think that probably, like, I guess, validated that, yes, I had been quite unwell and that I'd had these residual symptoms, which not everyone, I wouldn't say that's an advantage to have been that unwell, but it does kind of maybe my situation might have been viewed with a little bit more legitimacy than maybe some people who might have more gradual onset or subtle onset. But speaking to the GPs there, they, kind of recognized that these were symptoms I were having and kind of had labeled, it's post-viral fatigue or chronic fatigue. But there was just no real, it's kind of just like, this is something you've kind of just got to wait out or kind of deal with and, work within what you can, and we'll hope it gets better over time because, for a lot of people it might. But there was no real structured like therapy, I guess, because I guess we don't know enough, or we didn't know enough at that time. And I think, you touched on physio in the country area too. I think even now most physios wouldn't necessarily have a great understanding of how to manage chronic fatigue. It's very much a specialty area. So I could have potentially tapped into physio locally, but at that point it sort of didn't seem like the most appropriate modality because I was just already exhausted. Like the last thing that it's often counterintuitive to think, when you're having lots of fatigue and you're already struggling with day-to-day stuff, like why would I go to a physio who's going to make me exercise? Like that doesn't seem logical.
And that may well have been the case too at that time.
And it sounds like what you were saying is you were just see how it goes.
Yep.
Yeah. How did that make you feel at the time, if you remember?
Yeah, look, it's going back a while, longer than I'd like to admit. But I guess it was definitely frustrating, and all of the emotions you'd expect that would come with just like not being able to do the things that you did. Like I was super into playing soccer, and I had to give that up. I couldn't really go out as much with friends as much as I'd used to, or I'd just come back and crash. And so, as you'd expect, and as many people listening probably are very familiar with themselves, is it's really frustrating. It can really be, I guess, really disheartening and really take a toll, I guess, on your mental health, because it's a lot to carry, even when symptoms might not be, constantly at the most severe end of the scale, but they're really persistent and are interfering to that extent. It's tough. And I guess I was maybe, I don't know, I can't remember ever really getting stuck too much in I guess the really existential questions about it all, but it's definitely hard, I think, when you're in those sort of situations, and particularly for something like ME-CFS or a lot of these invisible illnesses, to sort of go, well, we don't really know what you can be doing, there's no specific recommendations, and we kind of just got to wait it out and see what happens. Like that's not a great vote of confidence, I guess, like, so it's, we always, like with anything, we always want answers, we want clarity, we want to know that we've got some degree of control over these situations. Even if the news isn't good, we sort of just want to know, okay, how does this look, and what are the prospects? And it's always hard, I think, not having that. So yeah, definitely.
And I hope you were really supported, but how was that perceived by the wider, your circle of friends or family or wider community, in terms of, I think what we see is this struggle with invisible illness and the perceived control over it. Like, well, why don't you just try that, or why can't you just do that?
Yeah, absolutely. It's I think for me, because I was still at the level where I could go to school, and I'm reflecting back and going, yeah, this kind of fits from that, I guess the autistic experience, but I was always quite academic and interested in school. And so for me, I never really was much of a studier. I would just do well and kind of wing a lot of stuff. So I think for me, unfortunately, and what I've actually observed clinically as well for a lot of people, even adults, is that if you are someone who can kind of push through to an extent.
I knew you were going to say that.
Show up in a way.
The push through. I think we'll just tag that one first.
Yeah, we do. We see a lot of push through.
Yeah.
And you know, people mask it, and it kind of becomes at a point sometimes where it's like, well, if I don't know how long this is going to take, and I am going to try to do what I can. And I think for me, the reality was, because I could show up at school, even if that meant I was crashing for hours after, if I could show up at school and my grades were still good, and, you know, everything on surface level feels okay, you know, we're not completely off the rails here, then it kind of just became something that it wasn't a priority. I have no doubt that if I had been more severely impacted and I was coming home sick every day from school, or I, you know, was, you know, failing classes and stuff, that it probably would have been more obvious, I guess, or apparent for people. But yeah, I think it kind of let me slip under the radar, which, I mean, I see that all the time with patients too, people who will smash themselves at work to get through and you know, carry out their commitments, and then really like pay the toll outside of that, but nobody ever sees that side of it.
Right, Sophie, let's open the box about what we're really here to talk about today, which is pain. And I feel like I'm going to ask a question which you could probably answer over 2 or 3 hours. But if you were to get to know someone who has been struggling with persistent pain, whether that's pelvic pain or back pain or another type of pain, and one of the things that we encounter a lot is a very one-dimensional biomedical lens over pain, which can happen in the clinical setting and also the community as well, discussion. And it doesn't take long working with pelvic pain to realise that it is not a one-dimensional biomedical issue. So if you do see someone, they might have had multiple laparoscopies, they're struggling with endometriosis, for example, struggling with pain, they might get a little bit of benefit out of something like a laparoscopy for a number of months, and they go back to where they were before. How would you explain the pain experience from your perspective to someone in those shoes? Because I think there will be people listening to this who are in those shoes.
Yeah, that's a great question. I don't know how well I'm going to be able to do that justice, to be honest, because I guess the thing that crops up for me is that whenever it comes to making sense of pain, it's such an individual thing, right? Like, and so I don't have a default way of explaining it, because I think we need to, if we're working collaboratively with people, we need to really tie in their experiences, and the way in which we explain it needs to make sense for them within their context too. So that disclaimer aside.
Fair enough.
I guess the thing that I would say is that it doesn't matter whether we're talking about endometriosis, whether we're talking about back pain, whether we're talking about even acute pain, like someone's sprained their ankle, or even pain associated with illness. It really doesn't matter what sort of pain we're talking about. The research we have now that's really evolved over the last couple of decades tells us that it doesn't matter whether there is or isn't, you know, I guess a clear driver of pain. All pain is complex. And so it's never just down to one thing. And I think that's probably the biggest challenge we have, is that that's often how pain is assessed and treated. And when that doesn't work, that's where we end up with people who are stuck. So the way that I guess kind of approach it is by sort of, I guess, highlighting that and saying, like, look, you know, if it were as simple as we'd like it to be, then yeah, the laparoscope would have solved the issues, because we've gone in and we've, you know, addressed the lesions, or we've gone in and had this surgical fix that, you know, has structurally fixed the problem, so to speak, but often that hasn't resolved pain. So it's like, we know there must be more going on. And I think endo actually in particular is an interesting example, because we know that the pain and the degree of, cramping and bleeding and all of the symptoms that go with endo actually correlate fairly poorly with the amount of lesions that people might have on, on investigation. So we know that there has to be more going on than just that, that tissue aspect of it. And I think, for someone with endometriosis, for example, I find it really helpful to then explore some of these newer ideas about how, it's known that inflammation in particular is sort of one of the key drivers, and understanding how inflammation comes about in the body as part of the body's regulatory and stress responses. Because when we link it to that, and I'm happy to dive in with questions after that to elaborate on that, but if we can understand it through that lens, and we can kind of then consider all of the things that might impact on bodily regulation and inflammatory processes in the body, that then opens up a lot of these other opportunities for things we can do to shift symptoms. So, yeah.
You've lovely sort of loosely described what we've talked about and know, clinically speaking, about the NEI ensemble. Mm-hmm. How do you talk
that being the interplay between the nervous system, endocrine or hormone system, and the immune system, and the way that might drive pain? Sorry, just for those who haven't heard that one before. I was going to expand on that. Thank you, Alicia. Yes. Do you talk to your patients about that, and not in those terms, but as a concept, and how do you address that?
Yeah, so I guess I probably see people who have had quite complex and persistent symptoms. So I guess the groups of people I'm working with often do require that kind of specific insight into those systems. If I were working maybe in a typical sort of musculoskeletal practice where I was seeing acute ankle injuries, I might not go into a full-blown, discussion of it then. But definitely in my context, it's something that at least the principles or the ideas is something that, comes a lot into what I'm often talking to people about and working with them about. And yeah, it's one of those things that I think, again, linking it back to the body's ability to sort of maintain homeostasis. So homeostasis, for those of you that aren't familiar, is a term we use to describe basically the ideal range of states that we want our body to be in so we can operate optimally. And we know that because we're a human being going about life and there's lots of things in our external environment, our internal environment that can throw things out of whack, maintaining homeostasis takes work. And so that's the process of kind of keeping us in those steady ranges is called allostasis. And allostasis comes about by the NEI system. So the nervous system, the immune system, and the endocrine system. Like we touched on just before, it's these three systems that work together and they kind of influence each other, but they work in a coordinated way, basically to adapt and protect and respond to these different challenges that could, I guess, threaten our body in some way or throw us out of homeostasis if we don't deal with them. So anything that potentially challenges our body or that our body has to kind of adapt to or cope with is going to place an added demand on our system. And that's where, when we understand it through that lens, again, because inflammation is part of that stress response and how our body adapts, anything we can do to kind of manage these various stresses and demands on the body it can be helpful in terms of reducing overall inflammation and symptom load.
So just to unpack allostasis a little bit more, from what you described there, I almost imagine it's like there's an invisible ledger where the load of anything that's happened to you, your genetics, any trauma, illnesses, overall health growing up, even I imagine, when you're like through pregnancy, all sorts of things, it's almost like there's a score that's kept somewhere, and that NEI ensemble, that interplay between nervous, hormone and immune systems somehow interact with that. What's your understanding of how and A, did I get that right? And B, what's your understanding of how those things work together?
Yeah, absolutely. So yeah, you're right. Basically, honestly, most things happening in or around us are likely to kind of represent a degree of allostatic load. There's actually some really good research exploring this now, even going to the extent of describing not just our immediate environment, but also even more broadly, the impact of things like, I guess more social aspects of our experience, like the neighborhoods and environments we grow up in, financial stresses, those interpersonal factors, like you mentioned, trauma can be part of it. But even then zooming in a little bit more on some of the more individual level things. So yeah, anything happening biologically, any illnesses or things that might place a demand on the body's systems, our mood, our emotional state, cognitive load, and then the lifestyle type factors too. So even, things like nutrition and sleep and gut health and, everything that kind of, I guess, places a potential demand on the body or influences our body's ability to adapt and cope is part of what forms that overall allostatic load. And our body can adapt to a lot of those things, but it takes resources to do that. And what happens when we look at some of these invisible illnesses is when there's a chronic sort of demand or overload of these different things, and it takes more resources than the body can replenish to maintain functioning amidst that. And that's when we start to see some of this multiple systems becoming a bit dysregulated. But that's why, because these nervous, immune, and endocrine systems are so closely linked and they do influence each other, usually if you'll have, an activation or a response in one of those systems, it will sort of prompt a reciprocal response in some of the others. So it gets really complex as to how these three interact. But that's why quite often, say if we take the example of, say, persistent back pain or a persistent pain after an injury, it's not unusual to find that if pain has persisted for a while, people will also start to experience other sort of systemic things that they didn't have before. Like they might start to experience like gut issues or sleep disturbances or hormonal issues. And it's like, you wouldn't think that these two are related, but when you think about that potential stress being placed on the system and the body having to work to maintain it, it can really throw a lot of things out of whack if that stress is prolonged. So yeah, it's complex, and like you said, could be here for hours and hours.
We could.
I'm quite happy to do that. But,
so happy to go down that rabbit hole.
So yeah, sorry. I was thinking, so a lot of the people that I see as a GP who come to see me with pelvic pain will come in with their symptoms related to their endometriosis or their pelvic pain. And I've said before, and I'll say again, that you can definitely have valid pelvic pain and not have endometriosis. Yep. And you can definitely have endometriosis and not have pelvic pain. But the common story, whether or not there's endometriosis there, if there's chronic pelvic pain, there's also headaches, there's poor sleep, there is fatigue, there is other body aches, there is neck and shoulder pain, there is so many other things going on, and it sounds like
constipation, nausea,
yeah, so many things, bloating. It sounds like that there is that interplay between those different systems feeding back into other systems.
Yeah, exactly. And you can start to see, what we were talking about before, where, those really linear biomedical ways of understanding stuff like A plus B equals C, you can see pretty quickly when you start to consider these situations and these models why that just doesn't work, because there are so many moving parts and I guess interrelationships between these things that there is this inbuilt sense of uncertainty, I guess. And for any one person, there could be so many different factors that are contributing to pain. And that's not to negate any structural or tissue-based things going on. Like absolutely for, people with endometriosis, addressing some of the, endo lesions absolutely could be part of what needs to happen. But knowing that it's more complex and that there are lots of things potentially contributing to this systemic dysregulation means that all of those things we mentioned that could be stresses, like the lifestyle aspects or the environmental aspects or other general medical conditions, all of these things then become potential targets to improve and kind of help manage symptoms. And I think from my experience working with people who've had endo, who have maybe had procedures that haven't been as successful as we'd like, from my experience and observations, that usually happens on the back of somebody who might have received potentially appropriate surgical care, but they haven't necessarily had support to look at these broader factors. And I suspect that that's probably why things might not have resolved.
So we've talked about what happens and potentially what's going on. We often talk about this in the context of what we can do to dial the system up or dial the system down. That's the terminology that we use. What do you find is then useful if you agree with that statement? Like what sort of things are you helping your patients understand in order to, I guess, be their own dial on this system?
Yeah. My goal is always to at least give people a starting point to understand, I guess, the potential factors that could be contributing. And the stuff that I specifically help people with it'll be different to what someone else might help someone with, because it will just depend on, I guess, any health professionals listening, I guess, where you feel comfortable in terms of your degree of training and scope and the bits you are and aren't comfortable. And I guess for any bits that I felt was sort of more outside of my scope, I'd be looking to connect with other professionals who can help support strategies in that space. But for me, coming from that pain space, we quite often having that education as, I guess, a starting point to understand the complexity of their symptoms, but also to recognize the actual patterns of their unique presentation. Because it's one thing to say, oh, these things impact, but what that looks like for the person and the specific things that might contribute more or less is going to be very unique. So gaining that insight. And then depending on the person, people might have certain areas that really stick out at them that they're like, I really know this is a huge trigger for me. So it's like, right, let's focus there. So if someone comes in and they say, oh, look, I've really noticed that my sleep's really disrupted, but the nights that I have a really horrible sleep, it really sets off a flare for me, and I feel awful for that. It's like, great, well, starting with some sleep, sleep strategies to try and improve quality might make sense for that person. We'll often talk about things like, we talked about sensory sensitivity before. If somebody is coming to see me, particularly if they're neurodivergent and they have lots of sensory processing issues, sometimes looking at relatively simple things like, can we give or start looking at use of things like noise cancelling headphones or sunglasses to try and cut down some of that added sensory load, for example, could be something we do. Often it's finding ways for people to explore safe movement and tolerable movement that doesn't trigger flares of symptoms, because I guess the overall goal is to get people re-engaging and being able to do more of the stuff they want to do. And the way that we do that is through a very gradual sort of exposure and building of tolerance, but it has to be really carefully done because we have to match it to where someone's symptom burden is at. And we're trying to really avoid that repeated getting stuck in this sort of boom bust cycle. So working with people to work out basically where's your system at right now, and like, do we need to kind of offload it and soften it a little bit first? Like, do we need to put some more restorative sort of practices or strategies in place so that you can regulate a little bit first? Or are you in a position where we maybe start adding more load? And it's just so individual.
Safe movement sort of flagged out at me there, finding what might be appropriate for someone. And as you were saying, sometimes that might not be the place that you start, even as a physio. I'm sure that that's almost programmed into you to think about movement first. What might that look like for someone? I don't know if you can think of someone that you've seen in a sort of de-identified way or something like that that you might walk through what that might look like. And I appreciate it's totally individual, and it would be, if you had 100 people, you might have 100 different strategies.
Yep.
Yeah.
So a really common example that I would see, if we take some of the stuff we've spoken about, potentially seeing, I guess, younger adult or maybe middle-aged woman who might be potentially autistic, ADHD, neurodivergent as an example, but not even always. I think even just that sort of, I guess, younger woman sort of demographic. Quite often I've found in that experience that people are being stuck in this very high intensity routine and lifestyle. So there's quite frequently there might be like very little downtime. They might be pushing through to get stuff done. Maybe they're looking after kids. Maybe they are trying to, engage in like things that matter to them, like hobbies and other commitments. But, they're just pushing and pushing and pushing and kind of constantly forcing themselves to get through stuff. And
I have no idea what you're talking about.
No, it doesn't apply to me at all. And I guess, so, if I look at, say, someone like that, which I would say is, I guess, maybe a common sort of presentation, I guess, if you want to call it that, but, a common sort of situation, I look at that person and they're having all of these fatigue and pain symptoms and maybe other GI issues. So if you look at that sort of whole situation, my brain goes to, well, it's seeming like their system's already under a whole heap of stress. They're really running themselves to the line here. Like, does it really make sense that maybe looking at adding more exercise is actually going to be the most helpful thing, or do we need to offload a bit? So for them, again, depending on the person, could be maybe can we like strategize around trying to work out how they can actually make even tiny, tiny spaces for breaks in their day? Like, can they just clock out for 5 minutes and just sit and breathe and give themselves a second to reset? Are there things that they can potentially look at offloading or delegating so that they actually have some recovery time? It might be looking at the activities that they do have to do and really push through, and like, is there a way we can soften them? So maybe we can't change the activity they've got to do, but maybe we can change something about it. Maybe we can, again, get them using sensory aids like headphones to cut down sensory load. Maybe we can change some of the position or look at equipment that might help offload some of that, or just generally trying to prioritize getting time in for enjoyable activities. Like, if people are just constantly smashing themselves at work and the kids and they're not taking time out, maybe it's, what can we do that actually gets you more stuff that actually lights you up and helps with that sort of restoration and recovery, I guess. And so, like, helping to calm down first in that sort of situation might be what it looks like. And it could be ages before we actually go, okay, let's really deliberately give you any sort of structured exercise. And for some people, I don't necessarily give them really structured physio exercises. For a lot of people, the focus is actually just, what's the activity you want to be able to do more of, and how do we get you returning to that in a really careful deliberate way where we can, gradually ramp it up and allow you to adjust back into it without triggering big symptom flares. And they might not touch any of their 3 sets of 10 exercises. So yeah, it very independent.
Nobody touches them anyway, do they, Sophie, really?
No, I said.
There's a lot of kindness in that approach. I mean, I would expect that there would be patients who would come and see you thinking that they'll be told, pull their socks up. And they're probably telling that to themselves as well, I imagine. You need to be doing more here. You need to be doing this better. You're not doing this well enough.
I need to be fitter. I need to be stronger.
Yeah.
Yeah.
Absolutely.
Yeah, that's how is that met? What happens when you have that conversation?
Self-compassion is a huge topic that I often will talk to people about. And I think it's universally true that, most of us are much better at giving compassion to other people than we are to ourselves. And so for a lot of people, particularly where they've maybe had years of trying to push through and maintain their responsibilities, or where they are, so passionate about wanting to help other people and to fulfill what they, their role in their family or their community, actually helping them to kind of, I guess, actually internalize that they are also deserving of rest and that they deserve to be gentle, and that they would, not necessarily impose the same demands or expectations on anyone else that they impose on themselves. And like that, I think we're often not great at having that compassion for ourselves, and that's such a crucial piece. So yeah, it's really hard, and it's not something that's an easy fix, even to say it, or even to, I mean, even with my experience, I can talk about it and I can be doing this with patients, but in practice, it's still really hard. And I still now often catch myself slipping back into some, I guess, less than compassionate self-thoughts at times around what I should be doing, or, things like that. And that's normal, because it's...
I was literally going to throw that back at you. So thanks for taking it upon yourself, because I was going to ask about your own self-compassion and you walking that walk, which it's incredibly difficult.
Yep. That's the thing. It's this stuff, even when we're talking about education and we're talking about pain and fatigue and all the things we can do, I think what's also really important to recognize is that people can have a really good understanding of this complexity, and they can be fully on board with yep, let's try this management, but that doesn't necessarily make it easy. It's not like, cool, we're sweet here, education's the piece. It's really hard sometimes to work out how do you then take that understanding and how do you put strategies in place in a way that works for you. And so a big part of what we often spend time on is actually, I mean, education's an important piece, but actually I find a lot of my patients are really informed already and quite aware of a lot of these things that might trigger them. It's actually more about, okay, we understand that, we're past that point, let's actually work together to figure out how do we actually get this working for you in practice? How can you actually translate this to your day-to-day and use it meaningfully so that you can then start to, I guess, see shift of symptoms with that? Because all the education in the world doesn't mean anything if we can't actually change stuff on a day-to-day or put it in practice.
It sounds like there's a real humanness to your... Is that a word? Did I make up a word then? Humanness to your practice. And do you think that we need more of that in healthcare? I'm not saying that we don't have it, but potentially can we, as practitioners, sometimes get caught up in clinical guidelines and education and the facts, and forget about not just, and I think we're really good at seeing the person in front of us, but also that the personable interaction of me as a person and you as a person collaborating together with my information and knowledge and experience to help you and connect and collaborate to find these solutions.
Oh, God, yeah. I mean, I have heard from so many patients that I've seen, the feedback that we get, and even just speaking to other people who have their lived experience, the difference it can make to sit with someone, and it doesn't matter if it's a doctor, it doesn't matter if it's a physio or a psych, or even someone who's not a health professional necessarily, but to have someone who can sit with you and to really hear you and go, this is I am hearing all of this and I recognize how tough this is, and to hold space for that while also, I guess, having that opportunity for support and to work collaboratively with someone. I think we underestimate the value of that. And I'm quietly convinced that a huge chunk of the benefit that people might get from seeing me is probably less to do with, super specific clinical skills, and more the fact that you've actually just got someone who can work with you to tackle it. Because, yeah, I mean, people have their own expertise in their own life, and, you know, there's a lot that they can tap into, and it just makes a huge difference.
I see it as we've talked about, we've got this system that's so overloaded. And so I kind of think about it in terms of like sharing some of that load. Like, give me some of that load for a little bit so that you can help make sense of yourself.
Yeah, absolutely. And quite often people have had, unfortunately, really negative experiences in the past. And these, particularly when we're talking about chronic fatigue and pain, invisible illnesses, you know, it's not unusual for people to have actually experienced, you know, medical trauma through the result of you know, trying to have these things investigated and treated, and have had really awful experiences going through the health system. And so, to have someone that will actually meet that with kindness and understanding, even if they're not necessarily, don't have all the answers or the solutions, but someone who recognizes it and sees it and is going to work with you. You know, for me personally, I know what a difference that can make, but I, you know, hear it all the time from patients as well. It's just makes such a difference.
Very powerful.
Absolutely. And one of the terms that comes to my mind is medical burnout. And so we hear a lot about practitioner burnout in the complex illness, persistent pain space, and I think that's a very valid thing to discuss, and as practitioners to make sure that we are looking after ourselves. But what I see with patients who come and see me, particularly when I initially meet them, and they really, of course, they don't know what to expect when they come and see a GP in a pelvic pain clinic, is they're burnt out. They are exhausted, not just from their invisible illness, but from the medical interaction. They're medically burnt out from what they have encountered over often years or decades or more. So, which probably leads me on to my next question, which is around, you mentioned earlier in the podcast, in the episode, around neurodivergent affirming care. Again, this could be a whole episode on itself, but how do you practice in a way that's neurodivergent affirming? Because many of the people that we look after with persistent pain have neurodivergent qualities, whether or not they're diagnosed or not. Yeah, what does that look like in your practice?
Yeah, it's an interesting one. And like you said, could be here for hours talking about this.
Yes.
In the interest of trying to, I guess, keep it as simple as I can, it's really just about appreciating, if we talk about, you know, neurodiversity affirming practice, it's just about appreciating that every single human we're going to encounter in life is going to have a different brain, a different nervous system, and different ways of processing and interacting with the world. So in some ways, it doesn't even rely on us knowing if someone is neurodivergent or, you know, ADHD, autistic. It should just be kind of a standard practice for all of us, and it's about accommodating those individual differences. When we think about neurodivergence specifically, or ADHD, autism, it's built on the premise that those differences, so say if someone is autistic or ADHD, rather than seeing ADHD and autism as a condition to cure and as dysfunctional and as, you know, I guess through that very pathological lens, which it has very much been viewed from that in the past, it's more about seeing it rather as a difference and working with those differences in a way that then supports somebody being able to access care and to live life to the best of their ability. So it's really shifting the way we're viewing these things from disorder to difference. And there's some really good references. I'm happy to even share them with you if anyone's interested afterwards. But, you know, at its core, it's about working collaboratively with people and building that trust, and also being willing to, I guess, adapt the way we do stuff on a day-to-day depending on what their unique needs might be. So in practice, it might be things like recognizing, for example, that someone may have sensory sensitivities that make it quite uncomfortable when they come into the clinic room. So thinking about relatively simple things like, when someone comes into the clinic room, can we just like flick the overhead fluorescent lights off because they're sensory hell and everyone hates them? So like, you know, giving people the option, or saying to them, you know, is there anything I could do that would actually make your visit to the clinic more comfortable? Some people might like to wait out in their car and then be called in when they're ready, rather than sitting in a waiting room, for example. Recognizing that people might have different communication styles and preferences, and being open to that, you know, particularly if people might have alternative or prefer alternative ways of communicating that are not verbal, giving the options for people to be able to comfortably and fully participate in care is really what it's about. And yeah, being person-centered and adaptive and really working from that place of trust.
Sophie, we're nearly out of time. I wonder if you had one takeaway, if there's someone listening to this show who is dealing with persistent pain and or fatigue, whether or not they're neurodivergent, have you got any tips for them or something that you would like someone in that position to leave this podcast with?
I think the first thing I would say is just know that you're not alone. It can really feel like it sometimes, but you are not alone. There are so many people out there who have experienced similar challenges, and it can feel so incredibly isolating. So know that there are others out there, and I guess where you can try to tap into community. If you're already listening to this podcast, that's a really good start. But listening to other people and connecting with others who are maybe coming at it from that place of understanding and finding people that you can share that load with is huge. But I guess the other thing that I would say is, if you can, really try to find somebody who is willing to view you as a person alongside these symptoms. So ask people for recommendations for clinicians or who they've had good experiences with, and because that's often the best way to know. And if you can get someone in your corner, again, whether it's a doctor, whether it's a physio, whether it's a psych, it doesn't really matter their background, but if there's someone that you can get in your corner that can kind of help see that and to help kind of then support ongoing care, that can be such a game changer. So ask people, seek these people out, look for people who might be a little bit more informed, because it can really be sort of the cornerstone for then tapping into, I guess, more informed supports. And it's so incredibly hard if people have had negative experiences, and I totally get the feeling of wanting to just kind of give up on medical support completely. But I guess there is hope and there are people out there. So, I guess try to hold on to that and seek it out if you can.
Sophie Sheppard, thank you so much for your time today. Thank you so much for sharing your story and your big heart with us. We'll have to put a warning on this podcast at the beginning to say, just have a tissue in your pocket, because I can feel tears myself and others who probably, even though you've not met them, will feel so heard and validated by what you've had to say today.
Yeah.
So
thank you so much for being so vulnerable and sharing as much as you have, and your patients in clinic are very lucky.
Oh, thank you so much. And no, thank you so much for the opportunity to come and chat about this stuff, because I think the more we talk about it, the more opportunities we have, for people to learn and tap in and I guess feel connected and share the load. So thank you.